My screen now.
Yes, we can.
Okay, so today we'll be talking about pulmonary hypertension. So, pulmonary hypertension just means elevated pulmonary arterial pressure. So, we're actually being particular about the arterial pressure. That's what we measure. So, the mean arterial pressure more than 20 millimeter of mercury at rest is defined as pulmonary hypertension. Please, we should take note of that. Elevation of the mean pulmonary arterial pressure more than 20 at rest. That is pulmonary hypertension. Pulmonary hypertension, just like what we know, about normal systemic hypertension, it can cause arteriolosclerosis. Arteriosclerosis. So this is not atherosclerosis. This is arterial. This means, if you guys remember, then in cardiology we talked about arteriosclerosis and um athero atheroma sclerosis. So when you are talking about the athero, the one that has atheroma, that's lipids depositing within the vessel. But arteriosclerosis is thickening or hardening of those vessels. So it's one of the complications of hypertension. And it's of two types. We have the hyperplastic and the hyaline. You guys remember. So hyaline is one that is more keeping with someone that has hypertension, although hypertension can cause it too. So you just have, you know, damage to the endothelial lining. You have extravasation of protein into, those intimal layer that brings about the hyalinization of those vessels, and they become thickened with that because the smooth muscle cells that constitute the tunica medial are going to lay down more extracellular matrix. So this will make the muscles more thickened and the vessels become hardened. Arteriosclerosis, one of the complications of hypertension. It also happens as a remodeling problem in people with pulmonary hypertension. Of course, the hypertension is going to cause the medial hypertrophy, just as I've said, lay down more extracellular matrix is going to cause thickening of the medial, and of course there's going to be some remodeling which includes fibrosis of the pulmonary arteries. Then plexiform lesions. These plexiform lesions is actually more common with someone that has idiopathic pulmonary hypertension. So it just means you seeing a vessel that contains so many lumen because the endothelial cells are branching out and they are forming new lumen. It's endothelial cell that lines the innermost layer of the lumen. So endothelial cells, migrate into another part of the lumen, colonizes that place and forms new lumen. So you are seeing like multiple lumen. Let me see if I can get an image, an histological picture that can demonstrate that. So you are just seeing vessel containing um, multiple lumen. Hmm. um, plexiform lesions. That means I have to share my screen entirely. Let me just do. Let me just do so that we can see it. Okay, plexiform lesions. Yeah. So this is what it looks like. I hope you guys can see my screen now. Can you guys see my screen now?
Yes.
Exactly. So we can see one here. This one endothelial. These are endothelial cells, lining one portion of the cavity of the lumen. So this is another one. You know, This is one here. This is another one here. This is another one here. Another one here within a particular blood vessel. So you guys can appreciate that. So it's one of the complications of pulmonary hypertension. Plexiform lesions within the vessels. So all these changes, the atherosclerosis, the medial hypertrophy, the fibrosis, brings about the remodeling, you know, options. So they are just remodeling activities that happen within those vessels, and at the end of the day they are going to increase the pulmonary vascular resistance because the diameter of the vessel is going to narrow, and when there is a narrowing of the diameter, there's a reduction in the radius, the resistance increases. So with the increase in the resistance, the afterload within the right ventricle increases. That's why the right ventricular pressure increases, and the right ventricle tries to compensate for that by undergoing hypertrophy. So one of those way we can clinically pick right ventricular hypertrophy on examination is when we palpate just beside the sternum on the heart. We are going to feel like a push to our hand. That's what we call parasternal heave. If someone has a parasternal heave at just beside the sternum, it's mainly caused by right ventricular hypertrophy. If someone has an apical eve, that is, you are placing your hand in the apex of the heart. You guys know the apex of the heart. Fifth intercostal space, mid clavicular line. Left fifth intercostal space, mid clavicular line. At that portion, apex of the heart. Someone that has 11 ventricular hypertrophy, you are going to find even at that portion. A push to your finger at that portion. So, but here, RVH, parasternal heave, is what we find. And of course, that can lead to right ventricular failure. When that right ventricular hypertrophy cannot undo that afterload, it's going to fail at the end of the day. So, what are the etiology patterns for pulmonary hypertension? It has been classified into 5 different forms: group 1, group 2, group 3, group 4, group 5. Okay, so the group 1 is just talking about affectation of the artery, particularly. So, because you know that the pulmonary vasculature contains the artery, the capillaries, and the vein. So, this etiology actually varies in the types of the component of the pulmonary vasculature that they affect. So, the group 1 is just entirely looking at affectation of the artery, particularly. So, before, under the group 1, we used to have only the idiopathic type. So, the idiopathic pulmonary hypertension or the idiopathic pulmonary arterial hypertension is only in the group 1. But now we've added some other causes. So, let's look at what the group 1 is all about. The group 1 is usually idiopathic. So, that means that we cannot attribute a cause to that pulmonary arterial hypertension. It's more common in the females more than the male, and it can be inheritable or it can just happen sporadic. So most common form are actually inherited. So that what the individuals inherit is actually a mutation within the bone morphogenetic receptor, the bone morphogenetic protein receptor, BMPR2 gene, the bone morphogenetic protein receptor 2. So this BMPR2 gene actually codes for a protein that helps to inhibit the proliferation of the vascular smooth muscles. So they don't allow uncontrolled proliferation of those smooth muscles within the vessel. So once there's a mutation of this gene, particularly a loss of function or an inactivating mutation, they lose this inhibitory action and there is uncontrolled proliferation of the vascular muscle, which brings about the pulmonary arterial hypertension that they develop. So that proliferation typically affects the arteries and it brings about narrowing in the arteries, which leads to the hypertension. So the other causes of pulmonary arterial hypertension in the class 1, can also bring about hypertension by causing damage to the pulmonary vasculature, particularly the endothelium, directly. And when there's damage to the endothelium, we cannot release of vasodilatory um, mediators like prostacyclins, that's PGI2, and nitric oxide that helps to relax, the the vessel. So instead of that, there's going to be increased expression of the vasoconstrictor. So that balance is altered. So the vasoconstrictors are more when there's damage. The vasodilators are less. So the vasoconstrictor that we are looking at is endothelin particularly. When it is highly expressed, it brings about vasoconstriction. So the other causes include things like amphetamines, cocaine. So amphetamines, cocaine have been noted to cause vasoconstriction. So they cause vasoconstriction of the vessels, of the arteries particularly. So in that way, they can cause pulmonary arterial hypertension. Connective tissue diseases like SLE, rheumatoid arthritis, because of the fact that they are type 3 hypersensitivity, you can have the inflammatory process affecting the pulmonary vasculature because it's a systemic problem. So they can affect the pulmonary vasculature, they can cause endothelial dysfunction from the immune reaction, which brings about increased expression of the vasoconstrictors, and also they can also bring about remodeling, increasing the thickness of the smooth muscle, which can explain the pulmonary hypertension. HIV infection too is being notorious to cause pulmonary arterial hypertension, especially in the advanced form. So people with advanced HIV have immune response to that HIV disseminated to the pulmonary vasculature, affecting the arteries, causing damage to the endothelium, and bringing about pulmonary hypertension. So portal hypertension too can cause pulmonary arterial hypertension because there's something we call uh, uh, portopulmonary hypertension. So there's portopulmonary hypertension. In portopulmonary hypertension, what essentially happens there is that because in portal hypertension you have bypass of the liver, so all the um metabolite that's supposed to be excreted and disposed by the liver, particularly serotonin, is not being metabolized by the liver. So it gets directly to the pulmonary vasculature, and serotonin has been observed to have a trophic effect on the pulmonary artery, smooth muscles, and the endothelium. So it causes proliferation of the smooth muscle. It brings about smooth muscle hyperplasia and hypertrophy. That's serotonin. So serotonin is normally should be metabolized by the liver. In portal hypertension patient, it is not metabolized. You guys remember, in portal hypertension, you have increased pressure within the portal tract, portal vasculature, maybe due to the fact that there's an obstruction within the liver or below the liver or at the liver. So when that obstruction occurs, you have more blood flow backing up within the pulmonary vein, the portal vein rather. They find their way to the systemic veins because of the anastomosis that they experience, that they have. So from there, they can find their way into the left gastric, they can find their way into the interior rectal vein, they can find their way into the periumbilical vein, depending on the level. And from there, they can get into the systemic circulation, it travel to the lungs, pulmonary vein, capillary, then to the arteries, where they cause, the problem that they bring about. So serotonin is there, is not, metabolized by the liver, and it can cause those hypertrophic changes to the muscles that we have talked about. So people with congenital heart disease, like someone with a BSD, that
But Baba, please, I didn't get that serotonin stuff. Sorry.
Can you repeat the serotonin pathway something?
Sorry, I didn't get the serotonin. So sorry.
okay. So what I'm saying is, people with portal hypertension, if you remember portal hypertension, it means that there's an increased pressure within the portal vessel, the portal vein, right? That's what it means. Now, when there's an increased pressure within the portal vein, the next thing that will happen is you open up the collaterals. You open up the collaterals between the portal system and the systemic circulation. You open up the collateral between the portal system and the systemic circulation. So I've tried to mention some of you know, the collateral. So the esophageal vein and the left gastric vein, you have a connection there. That's why you can have esophageal gastric varices. You have a connection below between your middle and superior rectal and the inferior rectal vein. So the inferior rectal vein is one that is draining into the systemic circulation. Your superior rectal and your middle rectal drains into the portal. So if there's increased pressure within the portal, those veins will not be able to move into the portal. So they have to shunt to the systemic side. So they go into the inferior rectal, and from there they empty into the systemic circulation directly to the IVC. So from when they get to the IVC, it travels to the right side of the lungs. They find their way to the pulmonary artery. Do you get that? Do you remember the portal stuff?
Yeah, my issue is the serotonin part. How does
Yeah.
serotonin come in?
Okay. So what I'm saying is serotonin normally is metabolized in the liver. When someone has portal hypertension, do we have fluid? Do you have blood delivered to the liver? No. That is why people
Okay, so because blood is not reaching the liver, I get the portosystemic anastomosis and the shunting when there is an obstruction,
okay.
like in ascites and the like. So I just wanted to understand why serotonin is like a major issue with pulmonary arterial hypertension. She
Yeah,
gets.
so many metabolites are dangling in the blood. Even ammonia is there,
Okay.
is not being excreted.
Yeah,
So
yeah.
exactly. So the
Okay, okay.
the serotonin component here, if you want to explain the
Mm,
encephalopathy, you talk about ammonia. You want to explain this
mm-hmm.
pulmonoportal hypertension, you talk about serotonin. So serotonin is actually the component that finds its way to the lungs. You guys remember that serotonin is also what is implicated in people with um
Carcinoid.
carcinoid. Yeah, exactly. So that's
Yeah, yeah, yeah,
actually a very bad guy. So it gets to
yeah.
those pulmonary vasculature and causes remodeling in the way of hypertrophy of the smooth muscles of the artery. So it gets to the artery first. So in the artery, it causes that remodeling, and it can explain.
Oh, okay. So because the liver is not metabolizing that serotonin,
Mhm.
by virtue of the shunting, it enters systemic circulation and then
Exactly.
enters into the IVC and goes to the right heart.
You're
The right
right.
heart takes it to the lungs and then it goes to worsen Okay, it goes to now go and cause remodeling of the
Exactly. The smoke must go.
pulmonary vessels. Okay, okay.
Exactly.
Then just to clarify quickly, carcinoid syndrome and carcinoid, this thing, the one that if it's lungs, and then if it is it's called
Like
syndrome, something
Yeah.
about the lungs and the liver.
The
It's
lungs, the
catching
liver.
in my head just now.
Are you talking about carcinoid syndrome can only develop when there's metastasis.
Okay,
So
that I think this is the part I'm talking about. So
yeah, when it
carcinoid is only when there's met to where
to the systemic circulation bypassing the liver. So there's just metastasis through the
intestines and all that.
exactly. So it's just
Also, because it is metabolized in the liver, you cannot say someone is having a carcinoid tumor in
yeah,
the
because
GIT.
mhm, because it's
Yeah,
already
yeah, I get it now.
metabolized by the
It
liver.
will be metabolized already. Thank you so
So
much.
yeah, you're welcome. So yeah, so that's that about the portal hypertension. Then
sorry about just an addition. So that means what you are describing now is sort of like a metastasis too, because I mean it's not being metabolized by the liver. So
yeah, it's a
the
shunt. Here it's not metastasizing, it's just shunting. Here you get it's shunting the liver. There's a portal hypertension. That means that you cannot portal vein should deliver blood to the liver. Do you get? Portal vein supplies the liver. Portal vein is the vein that feeds the liver. So so if you don't have the portal vein delivering to the liver because there's an obstruction, what will happen to the pressure in the portal vein?
it should be high.
It will be
Like,
high. So what do you think will happen? That blood will want to go back to go and pass through other anastomosis. And you know that
okay,
there's a portosystemic anastomosis. So it will get to the
yeah.
systemic vessels. And you know that all the systemic vein, they empty into the IVC. So when they get to the IVC, it delivers the component that is supposed to go to the
Right.
liver to the heart. Do you get it?
Okay. I do.
Yeah.
Thank you.
So congenital heart disease, there's a bypass, there's a shunting, between let's say there's a VSD. So that means that you're having a lot of blood flowing from the left side of the heart to the right side. So when there's the you have too much blood, getting to the right side, there's going to be a volume overload on the right side, and the pressure on the pulmonary vasculature is going to rise. So they can have pulmonary hypertension. That's just that about the congenital heart disease. Then schistosomiasis. Schistosomiasis one is actually more, aside schistosomiasis causing portal hypertension. I'm sure you guys are aware schistosomiasis can cause portal hypertension in our GI. It can cause. Hmm? I hope we are aware. It can obstruct those
Yeah,
pulmonary vessels.
yeah, yeah.
Exactly. Then schistosomiasis produce some eggs. When they lay down their eggs, those eggs can actually embolize inside the vessels, and this one of the areas where you have increased narrowing of the vessels is actually the pulmonary circulation. That's where most of those things get trapped. So it's only fat that is able to escape those pulmonary vasculature and cause its own symptoms. Majority of the other things get trapped within the pulmonary vasculature. So those eggs can get trapped within the pulmonary vasculature as they are traveling from the heart, following their dissemination into the vessels. And when they get to the lungs and they are trapped, inflammatory process happens, which brings about release of cytokines that cause endothelial dysfunction. So from there, you can have the vasoconstriction kicking in and reduced vasodilation. So that's that about schistosomiasis. All right. So the next group becomes very easy to separate. Now, the next group is talking about left heart disease only, causing the pulmonary hypertension. It is left heart disease, and this left group is actually causing majorly a pulmonary venous hypertension. I'll tell us why. So for us to say left heart, that means that the problem is on the left side. Let's say this guy has a mitral stenosis or aortic regurgitation. So what will happen at the end of the day is that you have a lot of blood flow backing up in the left ventricle, in the left atrium, depending on what you are looking at. Let's stick with mitral stenosis. There's a lot of blood, pulling within the left atrium. From the left atrium, they get back into the pulmonary vessel, increasing the pressure within that pulmonary vessel. So the pressure can also be transmitted downward to the pulmonary capillary and the pulmonary artery. So causing pulmonary hypertension at the end of the day. Do you guys get it? So it's systolic or a diastolic dysfunction affecting the left side of the heart. Maybe This guy has a left ventricular hypertrophy, maybe from hypertrophic hypertensive heart disease, or the person has a dilated cardiomyopathy, and the left ventricle cannot pump out blood very well. They are going to pull up within the left side and can cause pulmonary hypertension. So that's why people with heart failure can present with pulmonary edema. So that's just the mechanism. Then valvular disease like mitral stenosis that we have talked about. So I know that this left heart disease is very easy to understand. So if it's not the left heart, it can also be affectation of the lungs. So, but the lung one is actually, you can relate it with hypoxia. Hypoxia is the easy way out for the lung disease. It's a final common mechanism for the lung disease, although some of them can work without the principle of causing hypoxia. I will explain. So, group 3 lung disease. Group 3 lung disease. So, some of them can cause destruction of the lung parenchyma. Like someone with COPD, you are destroying the elastic fiber surrounding the alveoli, and at the end of the day, you are increasing the compliance and you are reducing the elastic recoil. And elastic recoil is very important to help us bring out those air during expiration. So that means that during expiration, they don't get emptied. They get, they just keep filling during expiration, and all the air that is supposed to move out during expiration is not moving out. So as you are taking in air during inspiration, the alveoli get ballooned out, and at the end of the day, you have hyperinflation. So that hyperinflation can actually cause compression on the pulmonary capillaries. So I want you guys to picture the way the respiratory unit, the interface looks like. You guys remember that the alveoli is one on top. Then next to the alveoli is our respiratory membrane. Then just beneath our respiratory membrane is what? What is beneath the respiratory? The pulmonary, the what?
What is it, the Avella or something?
No, the alveoli is on top. The alveoli is on top from the head. It's taking it from the lungs. From
Okay.
the
It will
head.
be the capillary.
Yeah. So the capillaries you want beneath. So just imagine that someone has hyperinflation and you're having hair trapping within the alveoli. What happened to the capillaries? What
It
happened to the
won't be. It will rest on it.
It will rest on
It
it.
will
Exactly.
rest on it.
It will rest on it. So what will happen to the pressure on the artery side that is emptying into the capillary?
It will not be able to pour inside it, so the pressure will also increase.
Exactly. So the pressure within the pulmonary artery will increase from that lung disease, causing destruction of the parenchyma like COPD. So that's the making for COPD. So the making for lung inflammation with eventual fibrosis, like someone with interstitial lung disease, is due to the fibrosis. Of course, when there's pulmonary fibrosis, it's going to affect the vessels too. There's going to be fibrosis of the vessels too. So blood flow within the vessels too will be impeded, which can explain the hypertension that they experience. Then the last one is hypoxemic vasoconstriction. I want us to know that this hypoxemic vasoconstriction can be central to all of them. At the end of the day, someone has pulmonary fibrosis is going to be shunting. Someone with COPD is going to have hypoxemia, and all of them will actually have that vasoconstrictive response to the hypoxemia that can drive the pulmonary hypertension. But hypoxemic vasoconstriction might only be the primary mechanism for pulmonary hypertension in someone with obstructive sleep apnea or someone living in high altitude. So we know someone with obstructive sleep apnea will have hypoxemia during the apneic period, so they can have hypoxemic vasoconstriction that brings about the pulmonary hypertension. And we also remember that people with the obstructive sleep apnea also experience systemic hypertension. We explained that due to the increased sympathetic discharge that we talked about yesterday. Then people living in high altitude are not taking in enough oxygen. So the PiO2 in this kind of people and the P big AO2 or the partial pressure of oxygen in the alveoli is going to be low, which also transmits to a low partial pressure in the arterial blood, which brings about the hypoxemia that causes the hypoxemic vasoconstriction. So group 3 is actually looking at lung disease or anything that can cause hypoxia. That's group 3. Group 4 is chronic thromboembolic event. So people that suffer recurrent PE, you know, PE to the pulmonary vessels, occluding those vessels. At the end of the day, there's going to be scar tissue being formed when it is recurrent. There's going to be scar tissue that's being formed within the pulmonary vasculature. Some remodeling will happen, narrow the vessel. There'll be there will be an impedance in the blood flow, which will cause, also because of the scarring, the cross surface area of pulmonary vascular bed is going to reduce. And every if the area is reduced, for the area to reduce, the radius, everything diameter will be reduced. So the resistance increases. So at the end of the day, the pressure increases. So that is that about the chronic thromboembolism because of the scarring reducing the area, narrowing the passage, blood we want to pass through with a higher pressure. So that brings about the pulmonary hypertension in chronic thromboembolic. That's a group 4. Then the last one is the group 5. So group 5 is anything that, is multifactorial or is idiopathic, something that we cannot really put out the mechanism. Aside idiopathic one for this mutation, you can have some causes that is idiopathic that they don't even have this mutation. So, but actually, most of what is actually classified in the multifactorial, particularly the one that is listed here, we can explain the reason why it's happening. So, let's look at the first one, hematology cause. So, hematology cause, like someone that has sickle cell anemia, someone that has thalassemia, these guys have, target cells, they have, what's it called? Sickle cell. So, the sickle cell, particularly, means that, you have occlusion of the vessel. So you can have occlusion around the pulmonary vasculature from the sickling of the cells. And remember that sickled cells can also cause shearing forces within the arteries as they pass through. So they can, cause damage to the arteries. They can even cause damage to the venous, any part, to the capillaries, and they are going to affect the endothelium. Endothelium is no longer releasing the vasodilators like prostacyclin and nitric oxide, which brings about increased vasoconstriction that can cause hypertension. So the sickle cell can also obstruct those vessels and can bring about the hypertension. So the pathophysiology of sickle cell anemia causing um, pulmonary hypertension is multifactorial. So many causes. So someone has systemic diseases. So systemic disease like, let's say, sarcoidosis, SLE, you know, these guys, someone, for example, someone with sarcoidosis now can eventually have pulmonary fibrosis. So yeah, it's a systemic problem. So we cannot actually classify it under lung disease only because sarcoidosis doesn't affect the lung only. It affects the skin, it affects the brain, it affects the liver, it can affect so many things. But when it affects the lung and it brings about the fibrosis, it can explain the pulmonary hypertension that they have. And there's a lot of remodeling that happens with the sarcoidosis due to the granulomas that you form everywhere, including the vessels. So metabolic disorder, particularly disorder like someone that has Gaucher's disease. So it has been prominent in some of those sphingolipidosis, like someone that has Gaucher's disease. There's accumulation of the glucose erythrocyte. They call them the Gaucher cells, so they can accumulate so many. That's why you see that when we get there, we'll be talking about something that presents as sickle cell anemia. So they have vascular necrosis. They have so many things that is bone pain, things that are in keeping with someone that has sickle cell anemia. And what is causing them is actually due to the Gaucher cells occluding the vessels. So they can occlude the pulmonary vasculature too, and they can cause pulmonary hypertension. So someone that has a lung tumor, so a tumor within the lung parenchyma that is compressing on the vessel, just like hyperinflation with COPD. You can compress on the vessel and increase the pressure. So it will be classified under the multifactorial. Okay. So let's look at physical findings in selective lung disease. So pleural effusion, we just go through them and we'll look at the changes. So one thing I just want to, make us know here is that we have different components that we assess during our respiratory examination. Um, we want to check for um the vocal and the tactile fremitors. So that means that we are just trying to assess the degree of sound transmission. So for the vocal transmission, we put our stethoscope on the chest, the lung zones, and we tell the person to make a very low frequency or a low pitch sound. It has been discovered that the 99 that we use in our local setting here is actually a high pitch sound and is not very effective in actually picking those fremitors. It's better to use something that is low pitch. So low pitch sounds um, are helpful in detecting the fremeter. So the only time that you can have exaggeration of those phonation or those transmission of those sounds that can be picked as our fremitors, both the tactile by placing the hand there and feeling the vibration, or the vocal by listening with your stethoscope, is only in a condition where you have thickening or hardening of the lungs. That is anything that can cause increase in the density of the lung tissue itself. And we call that consolidation. So the lung becomes consolidated when you have accumulation of fluid. Maybe it are not gas, please. When I say fluid, I'm not talking about gas. Because if some people might be talking about gas being a part of fluid, we are not doing physics here. So When I'm saying fluid, I'm not talking about gas. So fluid like maybe blood or exudate. So someone that has pneumonia and you have a lot of exudate accumulating within the alveoli, they can cause consolidation. So someone that has maybe a trauma to the chest, having blood accumulating there, it can cause consolidation to the lungs. Or someone that has heart failure with pulmonary edema, there's a lot of fluid backing up there, can cause consolidation. So that is the only condition that cause. Someone is trying to say something.
Yeah, yeah.
Okay.
Because when you were saying consolidation, I thought that consolidation was more of like fibrosis, something that would
No,
like. That.
no,
Mm-hmm.
no, no. It's not fibrosis. It's not It's just thickening. It's not that you're having fibrosis. If you're having fibrosis, that's another thing. It's not fibrosis. So consolidation is just in duration. When something becomes denser, it's just thickened. It's not actually fibrosed. No, no, it's not. That's what I used to think too when I was in medical school. But it's not pulmonary fibrosis. Pneumonia causing pulmonary fibrosis. It must be a very chronic form of pneumonia. So you don't have
There are stages like like the red hepatization, like
exactly.
the final stage of um
No,
the
no, no,
pneumonia.
no. The final stage of pneumonia is resolution. So, if you can have resolution, do you get? So from the um congestion, you go to the red hepatization, the gray, then resolution. So not not fibrosis. Maybe once in a it's not something that is typical. So if you are looking at fibrosis, you are thinking, okay, is it person having pneumoconiosis? Is it having exposure to radiation? Sure, you get. Is it having maybe um an interstitial disease, maybe rheumatoid arthritis, or a very chronic disease affects sarcoidosis. Those are what you look at. Pneumonia is more like an acute condition. Hmm? Pneumonia is more like an acute event. So that's it. It doesn't typically go, it doesn't progress to go to fibrosis. So it only causes consolidation. So consolidation is just when you have fluid um accumulating within the lung and causing the lungs to be thickened. That is it. That is consolidated lung. So you can see it in someone that has a lobar pneumonia or someone that has pulmonary edema. That's consolidation. So it's not fibrosis, please. It's not fibrosis. Yeah. So because of that increased density of the lung, it allows for conduction of those sound wave easily. So you can pick them up, as increased fremitors, increased vocal and tactile fremitors. In the other conditions affecting the lung, the fremitors decreases. Now let's take them one by one. Let me start with the breath sound. So this breath sound and fremitors, they are like the same thing. So if you um in conditions of pulmonary pleural effusion, atelectasis, simple pneumothorax, tension pneumothorax, the breath sounds are all decreased in these conditions. They are all decreased because in pleural effusion there is fluid within the pleural cavity, so it's very difficult for you to hear the breath sound because of that um fluid that's accumulating within those pleural cavity. Then atelectasis, the lungs are already collapsed, you don't hear the breath sound, it's very minimal. Pneumothorax is just more like a form of effusion too. So the breath time is also minimal. It's only in consolidation that the breath time is kind of exaggerated, and it's not as if it is okay. What we typically hear when someone has a consolidation is bronchial breath sound. That is, you'll be hearing a very high pitch sound that is similar to what you hear when you place your um when you listen to the air within the bronchioles, like or the trachea. So they are high pitch sound. So the frequency or the pitch of the sound reduces as you get to the alveoli. So by that time, when you are listening, you hear a vesicular breath sound. So it's kind of low pitch compared to the bronchial. But someone that has a consolidated lung, because of that exaggeration in the pitch and the frequency, you hear the bronchial breath sound. You guys should not worry yourself. And again, of course, we know someone that has pulmonary edema, someone that has pneumonia, you can hear crackles. Although this crackle um is not native to these guys only. It's not restricted to them only. You can hear it someone that has. So what other condition can cause crackles? Anybody? We've talked about this.
Actually, we talked about this later. Um,
That once you hear crackles, it's not only fluid that's coming to your mind, not only heart failure. So you can hear it in someone that has pulmonary fibrosis, someone that has interstitial lung disease from anything. You can hear it. We talked about it when we were talking about um uh idiopathic pulmonary fibrosis. We talked about it. Inspiratory crackles. You can hear crackles in that kind of condition. So it's not only consolidation that can cause crackles. Egophony and this pectorililoquy. So you guys should not worry yourself about this. This egophony just means exaggeration of the bronchial sounds with nasal component. So you are just hearing bronchial sound that is your fremitors rather, your vocal sound, yeah, definitely your vocal sound that is exaggerated and is having some nasal quality. So just like the person is speaking with the nose, you know, that's egophony. So when you have exaggeration of your vocal resonance, it's also called your pectorililoquy. So all these things are common with your consolidation. Just know that in the other condition, breath sound is reduced. It is only in consolidation that you hear bronchial breath sound. Okay, so let's go to the percussion note. So for someone that has a pleural effusion, it will be stony dull. It will be very dull. To be dull. Atelectasis too is dull. The only condition that can make the percussion note to be resonant is only when there's air there. So you only hear your percussion note being resonant when there's air. And the only two conditions that can make hair accumulate within the pleural cavity is what? A pneumothorax, maybe simple or tension pneumothorax. We are going to differentiate between these guys soon. So hyperresonant percussion note, our pneumothorax. Dull percussion note, pre-effusion, atelectasis, and consolidation. All of them will be dull. It's just that pre-effusion will be stony dull. But I don't think the white people pay attention to that stony dull of a thing. So they just assume everything to be dull. So, and of course, the breath sound is just like the fremiters. We said it that the only thing that makes the voice to be conducted readily and increase in, the frequency is what? Consolidated lung, a dense tissue, a dense tissue. So, and that is only, in consolidation. In the other conditions, the fremiters reduces because in this other condition, you have a longer distance for the sound wave to travel before you can get outside to the chest wall and be heard. It has to travel to the lung, travel to the fluid that is accumulating too, which is, in the case of tension pneumothorax, the air, in between that pleural cavity is another extra distance that it has to penetrate before it gets to the outside. So there's high chance of it being already being dampened by those resistance. Then in atelectasis, there's nothing to even conduct that air. The alveoli has collapsed. Then pleural effusion, there's also fluid accumulating within the pleural cavity. There's increased distance for the air to travel. It's possible that it has been, dampened and it can reduce the fremeter. So just know consolidation, fremeters increase. In other condition, it decreases. So for the tracheal deviation, so the way tracheal deviation works is that whenever there's an increase in intrathoracic pressure in one portion of the hemithorax, that intrathoracic pressure is going to shift, you know, the 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 trachea to or the mediastinum to the other side. So when the mediastinum is shifting, the trachea also follows it. That's what it is. So it tries to move the mediastinum, to the other side, pushes it away to the other side because of that pressure that it is exerting. And when there's less intrathoracic pressure in a region, the other region that has more pressure will push the mediastinum to the contralateral side that doesn't have much pressure. So let's look at that. So what are these conditions that can increase intrathoracic pressure? Someone that has an effusion, maybe a pleural effusion, or someone that has a pneumothorax. The pressure there usually increases. Pneumothorax or effusion. In consolidation, there's no increased pressure. It's normal. In atelectasis, there's decreased pressure because the lungs are collapsed. So the pressure there, intrathoracic pressure there reduces. So that means that someone that has a pleural effusion will readily push the trachea towards the contralateral side, especially if it's massive. So if it's small, it doesn't actually push because the pressure has not built up. But if it's massive, it pushes it to the contralateral side, and you have the tracheal deviation to the contralateral side. If someone has atelectasis, the pressure there is reduced. So that means that the pressure on the other side that have more pressure will readily push the trachea to the atelectasis side, the side of lung collapse, making the trachea deviate to the collapsed side of the lung. Yeah. So you don't have any tracheal deviation in someone that has a simple pneumothorax because in a simple pneumothorax, there's air within the pleural cavity, but it's not actually significant enough to cause compression of the lungs to be pushing it to the contralateral side. Because just picture the pleural cavity as a lining cover the lungs. So there's a lung parenchyma Let me see if you can see um what it looks like. Pneumothorax. Okay. So yeah. So can you guys see what I'm showing on the screen? Can you guys appreciate this?
Yes.
Okay. So you guys can see the lung. You can see the right lung. You can see, then we can see the space in between that right lung within it. So that space that contains those white things, that is the pleural space. Now, the pleural space is the space in between the visceral pleura and the parietal pleura. So the parietal pleura is this outer layer. Can you guys see this outer layer that my cursor is pointing on?
Yeah.
Exactly.
Yes.
So there's another layer that is actually investing on the lung itself. We call that one the visceral pleura. So the space in between them is what we call the pleural cavity. So that contains little fluid that allows the lungs to move up, move down during inspiration and exhalation. Okay. So someone that has a pneumothorax, you have air finding its way into that area, maybe due to trauma, due to collapse, bleb, due to anything. Hmm? Air finds its way into that region, and that air can start accumulating. Normally, that air can accumulate, and it might not be significant enough to compress on the lungs. Just you guys imagine that this pressure is accumulating and it becomes so massive, it compresses on the lung. Can you guys appreciate where it's going to push the lung to? It's going to try to push the lung to the contralateral side. Do you guys get?
Okay.
Exactly. It's going to push it to the contralateral side. But if you have air accumulating there and it's not pushing the lung, that is a simple pneumothorax. It's not exerting any tension effect on the lung. That's a simple pneumothorax. It can happen. So a simple
Okay.
pneumothorax can get complicated and progress to a tension pneumothorax. We are going to get to pneumothorax and we are going to shed more light on that. So in a simple pneumothorax, you are just saying, okay, there's no tension, so that means you don't expect any tracheal deviation. So you want to quickly rescue that person before tension pneumothorax happen. Hmm? Because if someone develops tension pneumothorax, the person can die of reduced cardiac output. Okay, so that's that about the tracheal deviation. So you don't have any deviation in the simple pneumothorax, you don't have any deviation in consolidation. So you guys should pay attention um to this part very well. Hmm? So it's very high. It's very high. You guys possibly see one of them in your exam. Okay, digital clubbing. Digital clubbing. So I think I have a picture that um talks about how digital clubbing works. So let me send the picture to the page so that we can appreciate what I'm trying to talk about. Okay, I'll send it to the page. So this finger clubbing of a thing is not even well understood. The pathophysiologic mechanism is not well understood, but it is said to be an increased angle between the nail bed and the nail plate. So if you guys can see what we have on the page, so the nail plate is actually the nail itself. That outer one that we can see, that's the nail plate. So the one that is beneath is the nail bed. Now, you guys can see this angle that they are talking about. Can you appreciate it? Hello?
Yeah. Oh,
Can you see what I've sent to the page?
to the page. Okay. Okay. Yeah.
Dr. Abisola, can
Yes.
you see it?
Yes, yes, I can.
Okay. So, in someone that has finger clubbing, you have exaggeration of that angle between the nail bed here and the nail plate. So, the angle increases to more than 180. But the pathophysiology of why you have this increased convexity is not actually known. But there's a there's a belief that it's common in some condition like respiratory disease, especially those that cause pulmonary fibrosis, cystic fibrosis, bronchiectasis, lung cancer. So, or some cardiovascular disease, especially the cyanotic congenital heart disease. So, respiratory disease, the chronic respiratory disease like cystic fibrosis, bronchiectasis, lung cancer, pulmonary fibrosis except COPD and asthma. Very important. Don't fall victim for it. COPD and asthma is not associated with finger clubbing. COPD is not typically associated with finger clubbing. It's not common. So, um, pulmonary fibrosis, cystic fibrosis, bronchiectasis, lung cancer, they can cause finger clubbing. Cardiovascular disease, particularly the cyanotic ones, can cause it. Then lung abscess and TB can cause it. Now, the mechanism by which um, the congenital heart disease can cause it is clear. So it's believed to be due to the fact that in people with congenital heart disease, like someone that has a TOF with a VSD, in the VSD with a TOF is actually shunting blood from the right side to the left side. So that means that you don't have blood delivering to the pulmonary circulation very well. And ideally, megakaryocytes, which are immature form of the platelet, as well as platelet themselves, they are sequestered and metabolized within or destroyed within the pulmonary circulation. So when you don't have that platelet or the megakaryocyte passing through the pulmonary circulation due to that shunting, they get escaped into the systemic circulation. When they get to the systemic circulation, they are easily trapped within the capillaries of the nail beds, the capillaries of the nails. So the digital vasculature, the capillaries there, they are trapped there. And megakaryocytes as well as platelet release some growth factors like platelet-derived growth factors from the name and vascular endothelial growth factors. So these growth factors have trophic effect. They stimulate growth, of the connective tissue of the nail. So which brings about the exaggeration of those angle and the convexity due to the excessive growth that they have from the effect of these growth factors. Now, it's been believed that these other conditions that causes finger clubbing is due to the fact that they themselves release these growth factors directly. So someone has pulmonary fibrosis, cystic fibrosis, there's increased production of these growth factors from the lung. Someone that has a malignancy of the lung, there's increased expression of these growth factors. TB, lung abscess, there's increased expression of these growth factors that exhibit the trophic effect on those fingers. So that is as well as inflammatory bowel disease. So we actually have a lot of things that cause finger clubbing. Even liver disease, chronic liver disease can cause finger clubbing. There's a lot. There's a lot. But once you see COPD or asthma in your option, do not go for it. And majority of what you should go for, with respect to the respiratory disease or the gastrointestinal disease, should be a chronic disease. A chronic disease. So pulmonary fibrosis, cystic fibrosis, bronchiectasis, lung cancer, your your cardiovascular disease that brings about the shunting, like your TOF, your other ones, your tetralogy of your Fallot, your total normal pulmonary venous drainage, and other things that bring about that shunting, like they can explain finger clubbing. So that's that about finger clubbing. Do you guys get it?
Yeah.
Okay. So let's go to atelectasis. Atelectasis is just talking about the collapse of the alveoli. So when the lungs collapse, that's atelectasis. There are different forms of atelectasis. There are different forms of atelectasis. So you can appreciate this X-ray that we are being given here. So you can see that we cannot appreciate the upper lung zone again. It has collapsed. You guys can see it's looking like you have cut off that upper lung zone. So it has collapsed totally. You can see it here. You can see it here too. So that is lung collapse. That's the way it appears. You just see that uniform opacity in that region. You know, you can say, okay, this is likely to be an atelectasis. So the way you can now know objectively that this is an atelectasis, doctors really ask, what do you do? If you want to confirm that this is an atelectasis now, what clinical sign will you check out for?
To confirm atelectasis,
Yeah, yeah. On the bedside. The bedside. So what
the
clinical?
you do the physical findings on the lungs,
Mm-hmm.
and if you look for the breath sound to be reduced, or or absent in that side or something like that, to be reduced,
Mm-hmm.
then the percussion would be also like reduced,
No,
since there's no there's
percussion, there's nothing like percussion note that is reduced though.
okay, sorry, dog.
It will be dull. It will be dull. Okay.
It should be
So
dull.
so what is a
Then
clincher? What's a clincher now? All those ones are common to so many things. So what's the clincher?
Is the one that will pull towards the like the lesion side, like um the tracheal deviation.
So where is this tracker going to deviate to?
It will deviate towards the part that is atelectasis, like the right
Exactly.
side.
Exactly. So that's the clincher. So once you just see that trachea deviating to that side, you know that that's where you have that collapse. Unless you have bilateral atelectasis. Okay. Yes. So
But Dr. Babari,
mhm,
you know that like now, for example, if something is going to a particular side,
mhm,
unless you're so sure that that's the side that does the lesion,
mhm,
sometimes if it was probably like maybe the maybe blood something causing like a tension, maybe tension pneumothorax from this side that is pushing it to the other side.
mhm.
You might not really know whether it is this side that is affected or the other side until like maybe the other findings that you're going to use to solidify your findings. I don't know whether I get what I'm trying to say.
Yeah, so let's just use it as an example now. This right side is having a tension pneumothorax. Now, no, don't let me use tension. Let me use pleural effusion. This right side is having a pleural effusion. Of course, when you try to listen to the breath sound, like you said, it's going to be dull. If this right side is also having that atelectasis, it's going to be dull. If you do a percussion note here, for the pleural effusion on this right side, it's going to be dull on that side too. Atelectasis is going to be dull. Now, when you now get to that tracheal changing, checking, this tracheal is going to move to the other side. It's going to move to the left in someone that has a pleural effusion.
Mm-hmm.
If you check your tracheal
Yeah.
deviation in this atelectasis, it's going to move to this right side, not the left side. So that means that you can narrow what your diagnosis would be. So
Mm-hmm.
it's actually easy to pick atelectasis than the other ones because atelectasis is the only single one that you can find all these reduced breath sound, dull breath sound, and your trachea will be deviated to that side. In the other ones, they will be most likely moved to the contralateral side. For example, in a pneumothorax, it's going to be moving to the contralateral side, but you'll have, nailed pneumothorax with your hyperresonance that you'll have picked from your percussion note. It won't be dull. So even your bedside clinical examination can help you narrow out all those things. Then you can now confirm with your X-ray. So yeah, so what are the multiple causes of the atelectasis that we are seeing? Obstructive disease. So if someone has an obstruction within the trachea, for example, maybe there's a bronchogenic carcinoma obstructing one of the main stem bronchi, and you don't have hair getting into the alveoli. So what will happen is the little air that is already present within the alveoli before that obstruction, they are going to get resorbed by the blood within the pulmonary capillary. So when those air get resorbed, what happens to the alveoli? Dr. Zuleya, what do you think will happen to the alveoli? If air has been taken out from the alveoli, you know,
I think
resolve,
it will
it
collapse.
will collapse. That is it. It will collapse. It will collapse. That is it. It will only open back when you relieve the obstruction and air flows down through the airway into the alveoli. That's when you can relieve it. So, what are those things that can cause obstructive atelectasis? A foreign body that's been aspirated, a mucus plug, particularly maybe someone that has maybe bronchitis or someone that has cystic fibrosis from anything or asthma, um, a tumor, a bronchogenic tumor like we've talked about. So those three things can actually cause the obstructive atelectasis. The compressive atelectasis is talking about you having a space occupying lesion, either a lung malignancy within the lung parenchyma that is sitting within the lung parenchyma compressing on the alveoli themselves, or you have pleural effusion. Pleural effusion is actually a very good one to explain. So you guys can see this effusion within this pleural cavity lining the lung. You guys can see that it's already exerting tension on this lung. It's already compressing on it. So they can compress on the lungs and eventually cause the collapse of the lung eventually when the compression becomes so massive. So that is compressive. That is not obstructive. Obstructive is from the airway. Compressive is from the parenchyma itself. Maybe from a mass or from the pleural cavity that's surrounding the lung parenchyma, compressing on it. So if you don't have compression, what else can it be? Can be due to cicatrization. Cicatrization is just scarring. When you have any inflammatory process that progress to chronic inflammation, like maybe someone that has sarcoidosis or someone that has pneumoconiosis, they can have fibrosis of that lung that will shrink that lung and to damage the alveoli. At the end of the day, they will collapse. Cicatrization. contraction. That is the mechanism of this. Then the last one, which is very common, is the adhesive type. Adhesive type, it just means that you have adhesion between the alveoli walls. They are adhering together. So that means that the elastic recoil there is what? Is increased, right? We've said it that elastic recoil is what is bringing them together, or surface tension is increased. So they are kind of attracting themselves. The alveoli are coming together. They are collapsing on one another. And one of those things that can cause that is when there's loss of surfactant. So, Dr. Abisola, can you mention any condition that can cause loss of surfactant that we've talked about?
Loss of surfactant.
Mm-hmm.
The only one I know is premature babies. Yeah, yes.
ARDS. ARDS. Yes. So we mentioned it with ARDS. If they tell us surfactant, even if we don't remember, we should always remember that prematurity. That one is constant K. That's the cause of neonatal respiratory distress syndrome, loss of surfactant. But in also an individual with adult respiratory distress syndrome, you also have loss of surfactant because of damage to the type 2 pneumocyte. They cannot produce those surfactant again. So, they eventually have exaggerated surface tension, and surface tension is the force that brings those alveoli together and they will collapse. So that one is not obstructive, it's not compressive, it's not contraction, but adhesive. They are there together. So the code is ABCC. A adhesive, B obstructive, C compressive, and cicatrization. Guys, is it clear to us?
Kind of. The adhesive. The adhesive is just basically due to the lack of surfactant, and that increases the surface tension and causes collapse of the lung, right?
Mm-hmm. Mm-hmm.
Like
Okay.
I really I've not been able to go further in tying it. Like aside from that, just that basics. That I
That is
really
it.
did not do.
That is it, doctors. Yeah, you don't need to go further again. When there's surface tension, you know, the reason why you have surfactant in the lung is to what? Is to reduce surface tension. If you reduce surface tension, the lung will not collapse. Do you get it, Dr. Zilian?
Yes. Yes.
So
Okay.
you remember that we also mentioned in ARDS that the cause of the collapse, one of the causes of collapse in ARDS is what? Due to the loss of surface tension, due to the loss of the surfactant. Do you get it? That is just it. When
Yes.
you have surfactant being absent, that means that surface tension is there. You remember that surface tension, we said it, that surface tension is the force that brings the alveoli together. You remember, like the inner layer
Yes.
of the alveoli, they come together. So when they come together, they collapse on themselves. That is just it.
Mm-hmm.
That means that surface tension has to be reduced at all times by the activity of the surfactant. Hmm? That is adhesive. It's very easy. Cicatrization is just the inflammatory process causing shrinking. So when it shrinks, it will collapse now. When something becomes fibrotic and it shrinks, it has already collapsed. That is it.
Mm-hmm.
It's just the
Mm-hmm.
fibrosis that is causing that. So uh compressive means that you have something compressing on the lung, trying to make it collapse. It's compressing on it to collapse it. So maybe you have a pleural effusion that is trying to compress, on the lung parenchyma, or you have a lung mass sitting within that parenchyma compressing on the alveoli. Those two things compressive. Hmm? Then, and in those ones, you are reducing lung volume because if you compress on it, there's no way, air can enter. Even the air that is already there, it will push it out and it will collapse at the end. Obstructive, that one you said it that there's an obstruction, air cannot enter. So the old air that are within that alveoli will be resorbed by the pulmonary capillary. And when there's no air within that alveoli, it will collapse. It will collapse because there's, nothing for your surfactant to even act on and be reducing surface tension. It will collapse. So that is the mechanism. Do you get it, Dr. Zlian? So obstructive,
Yes.
compressive, contraction, adhesive. Hmm? I tell you, takes this. So now, what do you want to do for them? So one of the ways you can start is by giving incentive spirometry. That is, you are just doing chest physiotherapy. I'm sure you guys remember those things that those guys used to blow. Do you guys remember those spirometry that they blow? Those things that looks like a toy that they tell them to be blowing. Some of them will improvise by using blown blow. They will connect blown blow to a pipe and they will tell them to be blowing it. So in that way, you are trying to increase.
did
Huh?
you really say bloom bloom?
Is it not
Yeah, bloom bloom in Yoruba wa pe now. Balloon.
blown blow balloon? Yeah. So doctor, don't mind doctor. I'm just like, let her be forming posh there. We know what she says at home. So, those guys are trying to, push in air and push out air from their lungs. So in that way, they are trying to expand the lung and, keeping the lung volume increased from the collapse. So that is what they do with chest physiotherapy. So
Has it at home. It's like you just drop the picture of the group.
the what? Okay,
The
doctor.
solution has it at home.
Doctor Rishala, let me see. Okay, yeah. Doctor Rishala na agba now. So that is it. That's the normal one. That's the way the normal one should be. So you are trying to introduce air. You are trying to blow. You're blowing air in and out of the lung, so that can help you increase lung volume with this machine. Then in people with adhesive type particularly, so these people you want to give them, the positive end expiratory pressure. You guys remember this? We've talked about it. Your PEEP, your positive end expiratory pressure. You can use it in someone with ARDS. We mentioned it when we were talking about ARDS because the problem there is that there is a lung collapse, and that collapse typically happen at expiration, because expiration is when the lung can collapse. But um if someone has loss of surfactant that is making the activity of the surface tension so exaggerated that is causing the collapse, you need to deliver a positive end expiratory pressure, that is a positive pressure that is keeping the alveoli open during expiration. Because in expiration, there's a tendency for the lung to collapse. There's a tendency. So, but it is, your surfactant that is helping us reducing surface tension that is, not making it collapse. So not just imagine someone now having a surfactant. That means that surface tension is there to be bringing the lung together. So it means that once the person try to expire and bring out air, they will collapse. They will collapse. So that is exactly what happens to someone with a COPD, or someone that happens with something that happens to someone with a ARDS, because in them surface tension is exaggerated. It you know brings the alveoli surface together and brings about the collapse of the lung. So you want to act on that surface tension by increasing the positive pressure within the alveoli that keeps it open during expiration. So that's why you give a PEEP. Because the problem, when you remember surface tension, expiration, expiration, expiration. In inspiration, air is entering, so the lung is already expanded. So you have less threat from surface tension. But the threat from surface tension is more when you are expiring, because when you're expiring, you are moving air out of the lungs. So surface tension has more room to act and cause the lung collapse. So that is why we are giving PEEP, not actually CPAP, but PEEP. Mm. So is it clear to us, Dr. Oluwatobi? Do we get it?
It is.
Okay, okay. Yeah, so let's quickly go to pleural effusion. Pleural
But the
effusion is just,
solution was the one that responded. It was me that responded. Oh. It was not Dr. Watobi.
yes, I know. I couldn't know, but I'm just thinking maybe she's busy or something. Dr. Abisola, do you get it?
Yes, yes.
Yeah, I'm actually with you. Thank you.
Okay. So, pleural effusion. Pleural effusion comes out a lot, and I feel it's a bonus. Once we see pleural effusion, we should just shout hallelujah and be very happy. So actually, we should be shouting hallelujah to see everything, because everything will be simple for us in Jesus' name. So pleural effusion just means you have fluid accumulating in between the pleural layers. We've talked about the visceral and the parietal pleura that is surrounding the lung parenchyma. So you can have fluid accumulating in between those layers. Now, what I want us to appreciate is that those pleural layers actually have capillaries within them that perfuses them. They too, they need blood supply, and there are lymphatics within them that actually drains those pleural fluid. So pleural fluid gets recycled with time through the lymphatics. The lymphatic will deliver it back into the thoracic duct and empty into the venous circulation. The parietal pleura is a component of the pleural cavity that actually secrete those pleural fluid. And both the parietal pleura and the visceral pleura are supplied by capillaries, by vessels that nourishes them. So let me come again what I've said. The pleural cavity is a cavity that is in between the visceral pleura that is just investing on the lung and the parietal pleura that is just within the chest wall. So in between them, you have the pleural cavity. And within that pleural cavity, you have pleural fluid. Pleural fluid is secreted by the parietal pleura to keep it lubricated. That pleural fluid needs to be recycled, so it is being drained by the lymphatics within that area. The pleural, both the parietal pleura and the visceral pleura have vessels that supplies them normally. Now let's now look at problems that can happen. The problem that can happen is when you have pleural fluid being too much within that pleural cavity, either due to the fact that its production is being increased, or you have more fluid moving from outside the capillaries into the pleural cavity, because we said it that they are lined by capillary by vessels. So fluid or blood within those vessels can actually leak into that pleural cavity. Or you have problem draining the pleural fluid with time due to problem with the lymphatics. Now let's take them one by one. So someone that has a pleural effusion have excessive accumulation of fluid within the pleural layers, and when there is increased accumulation of fluid within the pleural cavity, it compresses on the lungs. We've said it, a compressive atelectasis. So it will want to compress on the lung, and it will affect the expansion of the lung during inspiration. So the lung cannot expand because of that pressure from the pleural cavity. So typically, the cause can be two types: exudative and transudative. Now, this classification is actually based on so many parameters. But what you are going to be looking at here is actually more of what is causing it and how it appears. So let's just stick to what is causing it and how it appears so that we don't spend the whole day talking about pleural effusion. So the exudative type, they will appear cloudy. Why? Because of the fact that they contain cells and they contain protein. They contain cells and they contain protein. And the only way you can have cells and protein escaping into the pleural fluid is when you have damage to those capillary endothelium that supplies the parietal pleura. So within the parietal pleura, you have those capillary, those vessels. When the endothelium is damaged, the blood that is entering them contains protein, they contain cells. So they can escape into the pleural cavity, and they will be found to be cloudy and cellular. Cloudy because of the fact that the cells, they will die at the end of the day, then the protein also make it cloudy. So that's why one of the things that can cause exudative pleural effusion is what? Someone has an infection. If you have an infection, there's cytokines everywhere, they damage those capillaries. There's channel. You guys can see what we have here. So there's increased vascular permeability, there's channels, there's holes being made from those cytokines. So that means all the components of blood can escape through those openings into the pleural cavity that we can see. So things like pneumonia, tuberculosis, malignancy. Malignancy is cytokine reading. They have a lot of cytokine released with malignancy. So malignant cells can even destroy those capillaries themselves. So fluid will leak. So someone that has maybe a mesothelioma, they can have what type of exudate do we have in mesothelioma? We mentioned it. What type of pleural effusion? Can you guys
Yeah, an
guess?
exit.
Hmm?
Sorry, I have a transudate.
Ah, no, no. We've not got into transudate, doctors there. Malignancy. I've said it now that malignancy is affected with elaboration of cytokines that they
Okay.
damage those capillary. So cells, protein is going to find its way into the pleural cavity. Is that still transudate? That's not transudate, that's exudative. They have
That's
exudate.
exudate. Okay.
But what is peculiar to the mesothelioma one is that it is hemorrhagic. Blood will also follow it. Do you understand? It should be hemorrhagic. Hmm? Hemorrhagic. Connective tissue
Yes.
disease like SLE, like rheumatic heart disease, like so many of them, they can damage those capillaries too, those endothelium due to deposition of your immune complexes, and you can have the pleural effusion emerging from there. So in someone that has the uh what's it called, chylothorax. So in chylothorax, that just means you have lymphatic fluid, being present within that pleural cavity. That means that there's an obstruction with the lymphatics that drains your pleural cavity. So that means you have a lot of fluid accumulating within that pleural cavity. So the lymphatic cells, the lymph, everything accumulates within that pleural cavity. You know, lymphatic contains so many things. Fat cells, lymph, that's one of the components of lymphatic. Fat cells is there, protein is there, so many things are there. So they're supposed to be draining those lymphatic cavities. So if they cannot drain it, they will keep accumulating and it will lead to an exudative pleural effusion. Because of the fat cells, the protein, everything that accumulates, they're supposed to be drained from the pleural cavity. Now, trauma can also cause release of interleukins. Trauma can cause damage to the endothelium. It will also bring about exudative pleural effusion. You need to drain an exudative pleural effusion. So once you do a tap of the pleural fluid and you see that it's looking cloudy, you check the protein content, it is very high. You measure the LDH, it is very high. You are looking at an exudative process. You need to treat it. You need to drain it so that an infection doesn't get superimposed on it. Now, let's go to the transsudative. For the transsudative one, there's no damage to that capillary. The only thing that is causing that movement of fluid, not even movement of protein or cells, just fluid, pure fluid, is that there's an imbalance within the hydrostatic pressure and the plasma oncotic pressure. You guys remember when we were talking about GFR, we said hydrostatic pressure wants to move fluid out of those vessels. Oncotic pressure tends to help you keep the fluid within the vessel. So, if someone has an increased hydrostatic pressure, maybe from heart failure or anything that can cause sodium retention, maybe this person has a renin secreting tumor and there's a lot of sodium being retained with fluid accumulation, or this person has Cushing syndrome causing the same thing, or heart failure from any cause, hydrostatic pressure increases. So, the level of pressure of blood within the vessel increases. That's also transmitted to the vessels within the pleural cavity. So that means that you can have increased hydrostatic pressure more than the oncotic pressure, and you can have fluid being forced out across those capillary into the pleural cavity without damaging the capillary. So it's either you increase the hydrostatic pressure or you reduce the oncotic pressure. So what are the things that can cause reduction in the oncotic pressure? You are losing protein because it is the protein that exerts the oncotic pressure. So if you lose the protein in the body, in the blood, albumin particularly, albumin is a major protein that exerts that oncotic pressure. So if you lose albumin from, let's say this guy has a nephrotic syndrome, the oncotic pressure will be low. So that means that hydrostatic pressure can easily exert its own action to drive the fluid out. Sometimes you might not be having a loss of the protein, but you are not just producing enough protein. So someone has a liver cirrhosis, you're having reduced protein production from the liver, and at the end of the day, there's reduced oncotic pressure and there's fluid being forced down into the vessel, then into the pleural cavity, from the vessel into the pleural cavity. So this will cause a transsudative pattern. So once you see the question, the first thing, and you see that this person is having a pleural effusion, the first thing you want to ask yourself is, what is the cause of this pleural effusion? Is it heart failure? Is it a lung cancer? Is it tuberculosis? So that you can identify the type of effusion you are dealing with and how you can treat it. So for the transsudative one, you have to treat the underlying cause. But for the exudative, you have to treat the underlying cause and as well drain that effusion. So once you treat the underlying cause for your transsudative, the effusion clears up. Okay. So what are those investigative studies that you want to do? Someone has an effusion, the next thing you want to do a tap. So you want to do thoracocentesis. So you go to the chest, wall, and you obtain a sample of your pleural fluid. Then you analyze it. You do a chemistry of that fluid. So one of those things you want to check is what we call the pleural fluid protein, as well as your pleural fluid LDH. Now, part of the cells that are released when the endothelial cells are damaged is what? Part of the molecule that is released when the endothelial cells are damaged is LDH, that's lactate dehydrogenase. So, in someone that has an exudative effusion, you are expecting the protein within the pleural fluid to be more than that of the serum. So, or not exactly more, but it exceeds a particular ratio. So let's say the normal ratio should be less than 0.5. So when the pleural fluid protein is getting higher than normal, it will later, exceed that 0.5. So when the pleural fluid is accumulating and it gets more than 0.5, you are looking at an exudative picture. So pleural fluid protein over serum protein more than 0.5 is talking about exudative period. That is, that pleural fluid that you are obtaining, the protein content is high. And if you do the ratio of that protein to that of the serum, it is more than 0.5 because it's high. Okay. Now, the next thing is to look at the LDH in that pleural fluid. If the ratio is more than 0.6, so you just add 0.1 to that of the protein. If the ratio of the pleural fluid LDH is more than the serum LDH, and the ratio is more than 0.6, the ratio of the pleural fluid LDH to the serum LDH is more than 0.6 because of the fact that LDH is being abundant in that pleural fluid. You are looking at an exudative picture. That is telling you that the endothelial capillaries are being damaged. Then the last one is to, compare uh, the absolute value of that pleural fluid LDH. So you are not actually dividing it by the serum LDH. You are just looking at it. Is it more than 2/3 of the serum LDH? So you look at, the normal pattern of serum LDH. Maybe it should be 1 for the, normal limit, the upper limit of normal. Let's say it should be like 0.8 to 1. Now, the upper limit of normal is 1 for LDH. Now, you are now looking at the LDH you are obtaining from your pleural fluid. You are now getting like 0.6. 0.6 is not to 1, but it's still more than 2/3 of the upper limit. Do you guys get it? 2/3 would be like 75. That would be like 0.75. So, no, let me say 0.8. You are getting 0.8, and the normal is 0.8 to 1. So that is more than 2/3 of the upper limit of normal, which is 1. So do you guys get what I've just explained now?
So the upper limit of normal, like the normal range that you should get normally for the LDH is 0.8 to 1. So if the value of the LDH you are getting is around is like a two-third of the normal, that means it is, what's it called, the prior, like a prior effusion is occurring, I mean.
It's
So like
exudative.
now I'm trying to look at the two-third of the normal is 0.75, right?
Mm-hmm.
So now that then we also now have that the rotary fluid in LDH over the serum level is greater than 0.6. I don't really get that because greater than 0.6. Okay. Or greater, not equal to or greater than.
No,
Okay.
it's
Greater
greater
than
than. It's
0.6.
greater than. Greater than. So you are dividing it. What you are doing is
65.
that, you see, what you are doing in that ratio is that you are measuring both pleural fluid and serum. Do you get it? You are measuring both that pleural fluid that you are working with and that of the serum. You are measuring both of them. Then you are now dividing them. If you get a ratio that is more than 0.6, that is exudative picture. Do you get it?
What
Mm.
was,
Hello?
what was Dr. Julius talking about 0.75?
No, don't worry. I
So
will explain what he's saying. Do you get what I've just said now? You measure the pleural fluid LDH. You measure the serum LDH. You now divide them. You get a value that is more than 0.6. That is exudative.
okay.
You get it? Or, in a lab, we have a normal value for LDH. We have a normal value for all the parameters. Do you understand? Let's say that the normal value that we are looking at for LDH should be 0.8 to 1. Now, 1 is the upper limit of the normal. 0.8 is the lower limit of the normal. Now, you now measure your serum LDH. You now get 0.79. Do you understand? You know that 0.79 is not still up to 0.8. It's not still up to 1, which should be the normal limit. Do you get it, Dr. Julia?
Yes, I get it. I guess what I should have said was like if you're measuring like the pure fluid of the serum level of LDH, like the pure what am I saying again? Because it's like I'm kind of confusing the ratio with like the normal serum level. It's like I'm confusing it. I think that's my problem because I'm like, why are we having like one that is going to be greater than 0.75 and we're also having another value that is saying greater than 0.6? So I'm trying to differentiate which one is which now. So like the other one is saying that a prior free LDH that is greater than two-thirds of the normal serum level. That's like just like comparing the
The
normal
value.
Abi.
Mm.
So now when you're now ratioing it is the one of the 0.6, Abi.
Yes. So when you are talking about the one of 0.6, you are measuring both. You are measuring both. You are finding the ratio. What did you get when you measured both? 0.6 higher. That is excitative picture. Or I just measure one, which is my pleural fluid LDH. I just measure my pleural fluid LDH. Then I look at the value that I got. I compare it to what I should get for normal. What you should have for normal is 1. Do you get it? Upper limit of normal is 1. It depends on what the laboratory is using. You know, we have I don't know the normal limit for a day. Do you understand? So,
Yeah.
if they give us the normal limit, let's say that's why I'm giving you an example of 0.8 to 1 to be the normal limit. They've given you that normal limit. You go and measure your serum LDH. Once your pleural LDH rather, once you measure that pleural LDH, the value that you get, you now look at it. Is it within more than 2/3 of the upper limit of the normal? What is the upper limit of normal? 1. What is 2/3 of 1? 0.75. Now I measured 0.78. 0.78 is more than 0.75, which is the 2/3 of upper limit of normal. Do you get it? Of normal serum LDH.
Yeah, I get it now. Thank you.
All right. So, Dr. Olushola, do you understand it? Do you understand what we are talking about now?
Yes, yes.
Okay. So now I just want you guys to know that you can diagnose exudative sorry. You can diagnose exudative pleural effusion when you have one of that three. Either you measure the ratio of pleural fluid LDH to serum LDH, you get value more than 0.6, or you measure pleural fluid protein to serum protein, you get ratio more than 0.5, or you measure pleural fluid LDH and it is more than 2/3 of upper limit of normal. Any one of the three is enough for you to make diagnosis of exudative pleural effusion. So those criteria is actually called the light criteria. That's what we call the light criteria. Those three things, the light criteria. We should not forget that. So this is how an effusion will look like on X-ray. Just see homogeneous opacity. You can see here, homogeneous opacity. So we see the meniscus sign, you know, obliteration of the costophrenic angle and all those cardiophrenic angle, you know, ideally the meniscus sign, which is somewhere here. Now we can see on CT, we can see the collection here. Can you guys appreciate this red arrow before treatment? Hello, guys.
So, I cannot see down your screen. No, I don't know what I'm the only one.
Ah, oh my God. You cannot see my screen and I'm explaining pleural effusion. You
I
cannot see.
can see.
No, I could see your screen before, but now I was thinking maybe you were going to scroll down or something, but I did not see the down part of the image. That's what I was trying to say.
But me, I can see. I was seeing it before.
This is it.
Uh-huh. Now I
This
can
is
see it. Okay.
so you can see the red arrow showing pre-treatment. This is the effusion here on CT. You can see following treatment when they have drained it, you can see that homogeneous opacity of X-ray has gone. You can see that
Mm,
the log is now well aerated. And you can see that on CT it has reduced. So
mm.
that is pleural effusion. So that means that if you give us any question on pleural effusion, we should be able to figure it out. Don't forget, transudative, you are looking at things that can affect the hydrostatic pressure or the colloidal osmotic pressure, and they don't damage the capillary endothelium. What are those things
But
that can increase the hydrostatic pressure? Heart failure or fluid retention. What are those things that can reduce ocotic pressure? Anything that reduce protein. Protein losing enteropathy, someone that has nephrotic syndrome, someone that has a liver cirrhosis. Exudative, anything that can cause release of cytokines that destroys the capillary endothelium. Infection, malignancy, inflammatory diseases, like connective tissue disease, so many things, pancreatitis, SLE, rheumatoid arthritis, tuberculosis, pneumonia, malignancy, anything. So that is that. Okay. So let's talk about. I want us to stop at let me see. Oh, we still have a long way to go. And I'm thinking we'll finish tomorrow. I want us to finish tomorrow.
what do you want us to stop today?
malignancy, lung cancer. So we'll just continue lung cancer tomorrow. But I don't think we can get to lung cancer.
Okay, let's just continue.
So pneumothorax. Pneumothorax is just talking about accumulation of air within the pleural space, just like we said for pleural effusion. In effusion, there's fluid that is there, but in pneumothorax, it is air that is accumulating within that pleural space. How do they present? They have difficulty in breathing because someone that has air within the pleural cavity is compressing on the lungs. The lungs cannot move very well during inspiration, just like pleural effusion. They have dyspnea. So because of the fact that the lungs cannot move, you notice that expansion is unequal. There will be reduction in chest expansion on the affected side. So there's chest pain due to that pressure. If do your percussion note, is going to be what? Hyperresonant. Your tactile fermitus is going to be reduced. Breath sound is going to be reduced. And you can have deviation of trachea to the contralateral side if you have a tension pneumothorax. But if it's a simple pneumothorax, you don't have any deviation. So what are the type of pneumothorax that an individual can present with? A primary, so we can have spontaneous pneumothorax. Spontaneous pneumothorax means that there is no trigger for it to happen. It just happens itself. That is spontaneous pneumothorax. And it can be primary and secondary. So when you say primary spontaneous pneumothorax, that means you are saying a pneumothorax that happened without any trigger in an healthy lung. That is it, in a healthy lung, rather. So a lung is healthy, so that means it's a primary pneumothorax. And we don't have any trigger, you just have that pneumothorax happening, spontaneous pneumothorax. So primary spontaneous pneumothorax is pneumothorax that happens without any trigger, any cause in in a healthy lung. So what are those things that can predispose to primary pneumothorax? It's actually primary spontaneous pneumothorax. It's actually due to accumulation of what we call subpleural bleb or bullae or cyst. So when I was talking about what was I saying that I mentioned this bleb? I talked about something. I was talking about the bleb, maybe emphysema or something. So I talked about bleb being collection within the visceral pleura and the lung parenchyma. So the space in between the lung parenchyma and the visceral pleura, you can have collection of hair within those areas as blebs. So you just have cavity of air, between the lung parenchyma and the visceral pleura that surrounds it. Please, can you guys picture what I'm saying? Can you guys picture what I'm saying? Let me know
Yeah,
if, yeah. So the visceral pleura that is surrounding the lung and the parenchyma that the visceral pleura is surrounding, those space between that area, they can form some air fluid collection that I call the bleb or cyst. So I mentioned it that it's typically common in people that are growing very tall, people that are tall and they are thin. So in these people, there's high chance of them forming those bleb because the shear forces on their lungs is actually more. So those shear forces is what brings about the formation of those blebs. Those blebs can rupture spontaneously without any trigger. They just rupture. And when they rupture, air is going to pass through the visceral peritoneum into the pleural cavity and it can cause a pneumothorax. So it's very common in people that are tall and thin. And you tend to see these guys in, people that have Marfan disease. So they appear like this. So, but if you have tall, thin people that don't have Marfan syndrome, they are healthy. They can have those blebs, and those blebs can rupture, and you can have the pneumothorax. It has been discovered that the occurrence of this primary spontaneous pneumothorax is actually worse in people that smoke. So people that smoke, they have release of cytokines that brings about rupturing of those blebs. So it has been associated with smokers. So people that smoke, they have high chance of developing a primary spontaneous pneumothorax. That is primary spontaneous. Let's go to secondary spontaneous. So in a secondary spontaneous pneumothorax, you have is either you have blebs that are formed there, but that lung is actually diseased. So there's Marfan syndrome, affecting the lung, causing formation of those blebs. So Marfan syndrome is actually what is causing those blebs. So that lungs is actually diseased because it is not the person doesn't is not free from illness. The person actually have Marfan syndrome, or this person has emphysema. Emphysema is also one of these conditions that makes blebs to be formed within the space between the viscera and the lung parenchyma, because you remember emphysema can cause air trapping. So from those air trapping, you can actually have formation of bullae. So bullae are just larger form of those blebs. They are more larger. They are long,
there are airfield cavities within those spaces that we've talked about between the viscera and the lung parenchyma. They are larger than the bleb. So infections too, although the mechanism of infection is not actually well established, but we are assuming that people that have lung infection like tuberculosis, especially, they can have what we call bronchopleural fistulas, that is fistulas between the lung parenchyma and the pleura that can allow air to actually track into the pleural cavity because of the necrosis that happen within the parenchyma. So you can have formation of those fistula, those abnormal communication between the lung parenchyma and the cavity. So that's already a disease lung, you know, and you know you can just have that flow happening spontaneously. It's not as if there's trauma or anything. You didn't touch that lung. So just later, you can just have that massive flow of air from that connection that's been established, leading to development of that pneumothorax spontaneously. Spontaneous secondary pneumothorax can also happen in individuals that are mechanically ventilated at high pressure. So just picture someone being mechanically ventilated at high pressure. So you are pushing a lot of air at high pressure into the alveoli. So it will get to a point that the air will be forced to move out from those alveoli into the pleural cavity. They will have to move out because of the pressure is too much. So that's what we call barotrauma. So that is why if you want to mechanically ventilate somebody, you want to do it at a very minimal pressure and low tidal volume because you are scared of barotrauma. So hyperinflation of the air, rupture of the alveoli, escape of air into the pleural cavity. That is it. That is, barotrauma. That is barotrauma. Okay. So traumatic pneumothorax is no longer a secondary spontaneous pneumothorax. This is not spontaneous again. They have a cause. There is a what's it called? Um sorry. Yeah. So there's already a cause for that pneumothorax happening. Either you have a blunt trauma to the lungs, to the chest wall, causing rib fracture. So when there's a rib fracture, you can puncture the viscera peritoneum, or you can, you can puncture the lung directly, or you can puncture the chest. The chest wall you can have the puncturing from the outside. So there's rib puncturing the parietal pleura. So already you have a communication into um the pleural cavity. Or you can have any damage to the lung from outside, that's affecting the lung, damaging the visceral pleura, and you can have a communication into the pleural cavity. So a rib fracture typically actually punctures the parietal pleura. So when it punctures the parietal pleura, because that one is closer to the chest wall, so you can have an opening into the pleural cavity from that damage in the parietal pleura. You can have a penetrating, you know, injury, like someone that has a gunshot or a stab injury to the chest. You have damage to the parietal, the viscera, even the lung parenchyma itself. So you have an opening within the pleural cavity that air can enter. Or it can be iatrogenic. Maybe you want to pass a chest tube, or you want to obtain a sample of the lung. So you puncture the parietal pleura. In that process, you get into the lung parenchyma, you perforate both the parietal, the viscera, and the lung. So it can actually, cause an opening within that area that can introduce air into the pleural cavity, or barotrauma. So barotrauma is both classified under secondary spontaneous or traumatic. So because it's a form of trauma too. So yeah. So tension pneumothorax is now a condition in which air that is now moving into the pleural cavity gets so much that it accumulates within the pleural cavity and is not going out, and it compresses on the lungs. It shifts the mediastinum to the contralateral side. And one thing I want you guys to appreciate here is that as the pneumothorax is compressing on the lung, the intrathoracic pressure increases. When intrathoracic pressure increases, that means that the resistance at the pulmonary circulation increases. Your preload at the right side of the heart increases, so there's high tendency of having, backload of blood within the right side of the heart, causing an elevated JVP. So it can actually cause more like right heart failure. If that exists, it can also be complicated with the fact that if you have a shift with the mediastinum, because one of the mediastinum structure that you have is your IVC and your SVC. But we are looking at your SVC, IVC majorly, because SVC is still high up. So your IVC runs through a major length of your mediastinum. So that shifting actually can compress and kink the IVC. And when there's a compression of the IVC, you have a reduction in venous return to the right side of the heart. So reduce cardiac output, and the person has an obstructive shock. because you are having an obstruction of the vessels, reducing delivery to the right side of the heart. Just like someone has a PE. PE also causes obstructive shock. Tension pneumothorax is another cause of obstructive shock. Cardiac tamponade is another cause of obstructive shock. So at the end of the day, there will be hypotension, and your heart rate will increase to compensate for that hypotension by causing tachycardia. And of course, I've explained the reason why they have jugular venous distension, because of the fact that your pressure within the pulmonary circulation increases, which transmits upwards to the jugular vein that brings about jugular venous distension. So the main mechanism that actually leads to pneumothorax is actually when you have a traumatic pneumothorax. It can also complicate your spontaneous pneumothorax, your primary and secondary, but in most situations, your spontaneous pneumothorax gets resolved on its own. So the air becomes resolved by the pleural cavity, and you have resolution of that pneumothorax. But if someone has a traumatic pneumothorax, you have an opening already, maybe due to a gunshot. So if the opening is small, small air will just enter through that area, and it will fill the pleural cavity. So it might not be actually sufficient to actually cause increased pressure within that pleural cavity to compress the lung and bring about tension pneumothorax. So it might not, compress the lung and shift the mediastinum. But in someone that has a very wide opening within that chest wall, maybe you have a stab injury that is very wide and the opening is more than 2/3 of the size of the trachea. Air continues to move into that opening. And one thing about that phenomenon is that that opening forms a one-way valve, that as air is moving into that opening, as the person is taking in air, doing inspiration, air is not going out. Air doesn't go out. So for tension pneumothorax to develop, that one-way valve effect of that opening has to exist. So that as the person is taking in air is moving through the airways, and also majority of them are entering through that opening, overloading the pleural cavity. So at the end of the day, you have increased tension within the pleural cavity that builds up, compress the lung, and shift the mediastinum to the contralateral side. So when there is a mediastinal displacement, it kinks the IVC, reduce the venous return to the heart, and this brings about the reduction in cardiac output. So what you want to do is to seal that opening. You seal that opening. Then subsequently, you do a needle decompression by placing a chest needle in the second intercostal space to drain, the air within the pleural cavity. In some situations, it can be very massive. You are just doing that to relieve the obstruction. To now drain the air out entirely, you need to pass a chest tube. You need to do a chest tube thoracostomy so that you can pass all the entire air out. Then you can treat the underlying cause of the problem. So if it's a gunshot injury, you want to manage gunshot injury, you want to close that opening so that you don't have air being continually moved into that region. So your traumatic pneumothorax can actually cause a simple pneumothorax depending on the size of the trauma. If it's not too big, it will just be simple. Air will not continually move progressively into the pleural cavity. But if it's very big enough, air will move into that area continuously and it will not go out. It will keep moving, depositing within the pleural cavity because the pleural cavity can accommodate it. And with time, they will exert pressure on the lung themselves and to compress the lung, shifting the mediastinum. So you must always mention that one-way valve effect, that is, allows air entry during inspiration but doesn't allow air to go out during expiration. So that is pneumothorax. So you just see hyperlucency.
Please,
Yeah.
the image B, can you explain it? Because where they are pointing to collapse longer, all that, I'm not really getting the image
Yeah.
interpretation.
So look at this image. You can see that this middle and this lower zones have collapsed. You can see that you have um opacity at that region, and opacity defines lung collapse. Remember? Hmm? Hello. So
Yeah.
exactly. So it means that you have that that pneumothorax, that what's it called? What do I want to say now? That
The functional
you know
pneumothorax.
in that side. So you can see that the other side is actually hyperlucent. You can see that the lucency on that side too is more than the contralateral side. You can see. Hello? Can you see that?
Yeah, there's usually like a cardiac something in that area. So if I saw this action in normal day, first of all, probably the contour on that other side. I'm not. I don't think I would have figured it out. That's why I'm trying to
No,
know
you can't
what.
even appreciate the cardiac contour is being lost. Do you know why? Because this area that's having collapse should not be having this collapse here. You should still have lucency in this area. Do you get it? So it's like you are exaggerating that cardiac shadow. Do you get it? Because the lungs on this side is collapsed. See this side now. You should not have. I think the best way to look at it is to look at it
And
like
you
this.
look for vascular markings too, Abi.
Yeah. So, but vascular markings is not, the major thing here. You can see that, there's hyperlucency here. That means that here is actually accumulating in this hemithorax. Here is accumulating in this hemithorax, and it is pushing, the mediastinum to the contralateral side. So you can see that the tracheal is deviating in this contralateral side. You can see this trachea deviating. So the area of the lung below that lung that is hyperinflating, that is, how do I say this? Okay, so there's hyperinflation on this upper side. It is compressing on the lung zones below, and it's also pushing the lungs to the contralateral side. It's pushing the mediastinum rather, not the lung, to the contralateral side. So this is actually talking about a pneumothorax happening here. Pneumothorax, there's a pleural, in a pneumothorax you have here within the pleural cavity. So that means that you have, if you check the X-ray, you are going to see hyperlucency. Do you get it?
Yeah.
Now the lung area where that is being surrounded by that pleural cavity area is going to collapse, because both your pleural cavity and your lung parenchyma is responsible for your lucency of your lung. Like how dark it will appear. So if you have air within your pleural cavity, it will appear dark. If you have too much air within the lung too themselves, it will appear dark. Like someone that has a COPD. You know that in a COPD patient, the hyperlucency is not coming from here that is accumulating within the pleural cavity. It's actually, coming from here that is accumulating within the lung parenchyma itself. Do you get it? But if someone that has a pneumothorax, the hyperlucency is coming from increased air accumulating within the pleural cavity that is surrounding the lung.
Okay.
So that is why you are seeing this, slight hyperlucency that you are seeing here. And of course, that is going to compress on the lung. So you are going to have some areas of lung collapse. And this collapse is actually happening more at the lower portion of the lung. You can see, let's see. I want to show us a very good X-ray so that we can. This X-ray is abnormal. You can see this distortion of the cardiac contour. This is the way a normal cardiac contour should be. So, you're already having collapse at this area, you're having collapse at this area. So it's distorting that normal pattern. If only we can bring them together, we cannot bring them together. So here is where that collapse is happening, exactly this region.
Yeah.
So you can see that this is the region that's been distorted, this region here. That's why that contour is not being appreciated. So it's here. That one is actually complicated because that collapse is happening on the left side. If it's happening on the right side, look at this one now. Look at this one. You can see that you can appreciate this collapse very well. You can look
Yeah.
at this.
Yes.
You can see the hyperlucency on the upper area. You can see the
Yeah.
hyperlucency here. So let us see if we can see another one. It's very controversial because it's affecting the look at this one now. Look at this one. You can see. Look at this guy
This
here.
particular yes, it's looking like the one that is in the book. Okay, I see this one. Very clear.
You can see the hyperlucency.
Yes.
Yeah, so
Mm-hmm.
it's now compressing on the lung, so causing collapse on this side. You can see this entire side is already collapsed.
Yeah.
It's already shifting the
Okay.
mediastinum. So when you are seeing hyperlucency with collapse, you are likely thinking of a pneumothorax that has caused lung collapse. So that pneumothorax will no longer be a simple pneumothorax. What you are looking at is a tension pneumothorax, because you've seen the lung being collapsed and you have seen the trachea being deviated. That means you are exerting a tension on that lung and the mediastinum. Do you get it now?
Yes.
So please don't forget that fact. When you're having pushing, you know, it has to compress on the lung will give way, it will shift the mediastinum. to the contralaterals. And when the mediastinum shift, all the mediastinal content can be affected. Your IVC will kink and your tracheal will move to the other side. So it's only doctors there that is practicing this.
Dr. Babalis, I have a question.
Okay.
There was one, I don't remember whether it's NBME or U World. They were like, so they pointed at a lung that had collapsed and there was a pneumothorax. Do you get? Then I
There
said,
was a
what pleura can you see?
what pleura?
Yes.
What
Is it the viscera or the parietal pleura that is obvious in the X-ray?
okay. So
I'm going to find out. I can't remember if it's NBME.
Okay, that plural line, Abby.
Yeah, so the arrow was pointing at the plural. I
yeah,
can't remember if I picked parietal or viscera, and I can't even remember the answer. But I'll try and look for the
I
question.
think
But
the answer
please,
will be visceral because
it
you
was
tend to see.
viscera. I thought the viscera would be sticking to the lungs. So in pneumothorax, is it that the gas is separating the viscera from the lung parenchyma, or it's separating the viscera from the parietal, or it's separating the parietal from the chest wall? Do you get my question?
Exactly. So in pleural effusion, in pneumothorax, you are separating the viscera from the parietal. You are separating the parietal from the viscera. That is it. So your
So
parietal
that means you
attached
cannot even see the parietal.
exactly.
You can't
It
see
will
the
attach
parietal.
to the chest wall.
Oh, okay.
So that's why
Okay.
I'm going for viscera. So what you actually see is the viscera with the lung. Because what is happening in pneumothorax is that hair is accumulating between the viscera and the parietal pleura. That is what gives the pleural cavity. And the parietal pleura is the one that is lining the chest wall. The one that is sitting and investing on the lung parenchyma is the viscera. So your pneumothorax is just making your hair is like pushing the viscera towards the lung, adhering your viscera towards the lung, separating your pleura, from it, your parietal from it, so that your parietal will adhere more to the chest wall. Do you get it? So the one that you'll be seeing by this side is the one
Yeah, I
that is
think it's
attaching.
clearer now.
So that is it.
So you
But
were
would
going to say something. The one that's what?
oh,
Hello,
You
Dr.
said the
Lalo.
one that is what?
I said the one that's attached to the chest wall, that's your parietal. The one that is,
To the chest wall,
standing
but that one will not be obvious now.
exactly, it will
That
not
one
be
will not
obvious.
be obvious.
It will not be obvious. So
Okay.
the one that is investing the entire parenchyma of the lung, that is covering the entire
Is the
parenchyma of the lung,
viscera.
is your visceral. So visceral is all these ones that are is
Okay.
anterior. There's anterior that is covering it like this. Both the edges
Okay.
and the anterior surface. Your visceral covers your parietal pleura.
Okay. Okay.
Your pneumothorax.
Like in this CT scan now,
Mhm.
this one that we are seeing, this partially collapsed lung,
Yeah.
that layer that we are looking at that is very obvious on top of the lungs is
Yeah.
the visceral
Is your
pleura.
visceral pleura. Yes.
All
Yes.
right.
The visceral,
Thank
the,
you.
the parietal is attached to the chest wall. So you might not be able to appreciate that very well with your CT.
so I was going to also note that. So does that also apply for the spontaneous pneumothorax? Because the way you were describing the spontaneous pneumothorax was more
Mhm.
as if it was between the viscera and the lung parenchyma.
Yeah, so when it ruptures, it penetrates the viscera to enter to the pleural cavity. Do you get it? You know that the hair is accumulating between the parenchyma and the viscera. That's why I'm asking you guys if you can picture what I'm saying, because you need to picture it. If you cannot picture it, you will not get it. That bleb is forming between the viscera and the lung parenchyma. Do you get it? When it ruptures, it moves through that viscera to enter into the pleural cavity, because the pleural cavity is the space between the viscera and the parietal.
Yeah, I can picture it. So now, like I'm trying to see like the way Dr. Toby was saying. So like it's an inverse now, right?
Inverse as well. No, you are not inversing anything.
Because like from the tension pneumothorax, it's like the tension is coming from outwards and pushing the hair is pushing the viscera to the like lining the viscera with the lung parenchyma. So whatever she's saying, like that one, I don't know what I don't know where I'm explaining this now. So it's more of like that one. the viscera is what you'll be seeing on the radiograph that will be showing, right, Doctor? I'm
Yeah.
trying to see the way to explaining it. So now that one, the compression is coming from outside, like the compression is already within the pleural cavity and is pushing the viscera to the parenchyma. But this one now, the compression is coming from inside. Shouldn't it be pushing the pareata outwards? Do you
You
get
know
what
what?
I'm trying?
You know what, Dr. Zulia? You see, the
Yeah.
way me I answer Dr. Oluwatobi's question, I did not answer based on tension pneumothorax. In anybody that have a pneumothorax, you have that separation, either tension or simple. There's already that pneumothorax forming. So, pneumothorax is space, is like air between the space. What is the space? Viscera and pareata. So that means that if you have a pneumothorax, you have increased the space between your viscera and your pareata. And you know that normally viscera attached to the viscera. What is this viscera? The lung. Pareata attached to the lung cavity. So that means that you have more separation between those two guys. So viscera will go towards the lung, pareata will go towards the lung cavity. That is pneumothorax. You now say there is a tension pneumothorax when the pressure within that pleural cavity is now compressing on the lung, shifting the mediastinum to the contralateral side. There are two different things though. Do you understand?
Okay.
You are shifting the mediastinum to the control. Because you are compressed. We showed us one image the other time that fluid compressed on the lung. We should move it to the other side, and in the process you are going to move the mediastinum. That's the tension pneumothorax. But pneumothorax itself is like air is collecting into the space between the pleural cavity. So that means that you have your visceral pleura being pushed to your lung parenchyma more. And what you are seeing here on your X-ray more is your what? Is your lung parenchyma. These are lung fields. So what you are going to see more is your visceral pleura, not your pareata, because pareata will have been pushed more to the chest cavity. Do you get it now? Do you get it? So
Yeah.
that is the
Yeah.
idea that I used to answer our question. I'm not looking at it from the idea of tension pneumothorax. Tension pneumothorax is beyond that. Anybody can have what I've said, even if it is normal simple pneumothorax, they will still be said because air is already accumulating there. But is that
Okay.
air causing a compression? Is it exactly a tension by causing a shift? That is tension pneumothorax.
All right. Thank you.
So, guys, do you have any question before we call it a day? So, we just continue from pneumonia tomorrow, then go to the cancer, then we will round it up tomorrow.
It's likely we finish tomorrow, right?